Right. Good morning, everyone. I just wanted to take a minute to introduce myself. My name is Linda Wyant. I am a healthcare senior manager with Myers and Stauffer, and we are a national accounting and compliance firm supporting government-sponsored healthcare programs. I'm also joined by my colleague, Bobby Courtney, who's a principal here at Myers and Stauffer, and he will be assisting me with today's session. So this meeting is conducted for and on behalf of the Oregon Department of Consumer and Business Services. Information collected and recorded at this meeting is potentially subject to disclosure under a public records request. We are recording these sessions to ensure that we capture the feedback correctly. If you wish to speak and are uncomfortable with having a specific comment recorded, please let us know and we will temporarily stop the recording. And so we are here today on behalf of the Oregon Prescription Drug Affordability Board to solicit constituent feedback related to the use of upper payment limits, or UPLs, to improve drug affordability, and to gather any recommendations you have on improving drug affordability for Oregonians. I know joining us from the PDAB board, I have seen Shelley Bailey, who is the board chair, and Ralph has joined us as executive director as well. I'm not sure if Jane Horvath has joined yet or not.
I don't see her, Linda.
All right. Jane Horvath may be introduced or may be joining us at some point in time. And if so, she is with Horvath Health Policy and is also supporting the board with their work. So we do have some logistics as we move through the conversations today. Before we begin, I'd really like to thank everyone for attending. We all know that your time is incredibly valuable, and we appreciate your willingness to share your perspectives on this important topic. And so in order to level set, we do have a brief series of prepared slides that we will go through and review before we get into our discussion. This is generally taken about 15 minutes, and we just ask that you hold any questions or comments until we've completed the presentation. And then once we've completed the slide deck, we do have a series of questions designed to solicit your input and generate dialogue among the group. And during that time, we will not be able to answer specific questions related to methodology or affordability evaluations. However, we do have a mechanism for you to submit those generally to the PDAB for consideration. And once we get to that point in the session, we will ask you to introduce yourselves and speak clearly if you wish to make a comment so that we can accurately capture your feedback in our notes. In addition, we do ask that you please mute yourself when you're not speaking. Zoom does have a function to raise your hand to be recognized to speak. And so we would ask that everyone please use that so that we can make sure we don't miss anyone who wants to make comments. And lastly, we do recognize this is a very complex topic and one that will likely generate considerable feedback among stakeholders. And as such, we do have a second meeting to continue our discussion and allow everyone an opportunity to share their perspectives. So with that said, we will jump into the first part of the presentation. So a little bit of background. The Prescription Drug Affordability Board, which we do refer to as the PDAB or the board, was established within the Department of Consumer and Business Services and is committed to protecting residents of Oregon, state and local governments, commercial and employer health plans, healthcare providers, pharmacies licensed in Oregon, and other constituent groups within the healthcare system from the high cost of prescription drugs. The board was established by the legislature under Senate Bill 844 in 2021 and later codified into Oregon Revised Statutes, Section 646A.693. And again, our goal with these sessions is to get your perspectives on the use of upper payment limits or UPLs to improve drug affordability and to gather any recommendations you have on improving drug affordability for Oregonians. And these sessions will inform the board's work on developing a plan for establishing UPLs as required under Senate Bill 192. Through the authority granted by the Oregon legislature, The board is tasked with establishing a subset of drugs to review for affordability challenges within healthcare systems or high out-of-pocket costs for patients in Oregon's. And the Oregon PDAB continues to refine its work, so I would encourage you to visit their website for updates to their meeting schedule and activities. And their next meeting is scheduled for July 24th. And as noted, information on the board schedule, meeting schedule and activities can be found on their website at the location given on the slide. So for purposes of providing a little additional context, several other states do have established PDABs, with 3 of them, Colorado, Minnesota, and Washington, having full authority to establish UPLs, and the other states, given on the slides, having various approaches and authorities regarding their activities. Vermont is probably the most recent state to start to work on UPLs or prescription drug affordability, and have recently enacted legislation that tasks the Green Mountain Care Board with preparing a preliminary plan to develop and implement a program to regulate prescription drug costs. And that plan is due to the legislature by January 15th of 2025. Colorado is probably furthest along in the process and has initiated the rulemaking process to establish a UPL on Enbrel. And their rulemaking hearings on this will take place in September, October, and December. And they also recently deemed Cosentyx and Stelara to be unaffordable. So the Oregon UPL is described this way in the 2022 report to the Oregon legislature. And under their concept, they talk about establishing a maximum amount that can be paid for a prescription drug dispensed in Oregon, leveraging existing process of negotiating, but not being a regulation of how manufacturers list or set prices. And specifically, it would establish a maximum amount that can be paid for a prescription drug, similar to a federal upper limit or a MAC, or maximum allowable cost, such as those that are currently established and used in prescription drug reimbursement today. And importantly, intended to avoid impacting best price in Medicaid. UPLs are also intended to improve market function for prescription products that have a UPL by achieving one or more of the outcomes that are listed on the slides. And this particular work is adapted this particular slide's adapted from work conducted by Jane Horvath from Horvath Health Policy, describing in principle that UPLs should improve market function for prescription drugs, as I said, by achieving one or more of the listed outcomes. Everyone in attendance, we know, is very familiar with the complexities of the pharmaceutical supply chain. However, we have a number of different constituent groups attending these sessions, and they have varying levels of understanding of the supply chain. So for purposes of level setting, this slide was developed to illustrate the process for retail and health system or physician administered drugs and their associated system of payments, rebates, and product flow. In this diagram, we describe a situation in which the UPL could be implemented at the top of the supply chain flow. Or for another way of looking at this, again, from material that is adapted from work conducted by Jane Horvath, this offers a little bit different view of the concept that we presented on the prior slide. And again, it's specifically intended to illustrate the progression of the UPL through various parts of the pharmaceutical supply chain. And as noted, the UPL is intended to replace WAC, AWP, AAC, EAC, et cetera, as the metric for financial transactions within the supply chain. So as we wrap this up and move towards our focus group conversations, We wanted to highlight a few recent industry events that we thought might serve as a guide to how a UPL could work in the marketplace. And as manufacturers, I know you're extremely aware of this particular event, but notably, in January 2024, there was a decrease in the WAC of several prescription drugs. And this was driven, of course, by the recent change to the federal Medicaid drug rebate program rules, which impacted the rebate rates that would be paid by manufacturers, in some cases significantly. And in response, manufacturers for certain highly rebated drugs in the Medicaid space implemented reductions in WAC across the board for these drugs. This could serve as an analogy for how a UPL might similarly impact the supply chain. And I would urge you to keep in mind, we will come back to the concept in our discussion questions. Some of you participated in the survey that was provided in advance of these sessions, and we very much appreciate those responses. We will explore some of those same questions now in our sessions, and as I've said, we appreciate your feedback and comments. And just as a reminder, please remain on mute unless you're commenting. State your name and organization for us when you do make comments. And you can provide written comment as provided on this slide. I will pop this information into the chat in case anybody wants to, pull it down in order to be able to use it a little bit more easily. All right, and so with that said, Bobby, I will turn it over to you to kick us off for the actual focus group discussion.
Great, thank you, Linda. And just to reiterate Linda's comments, thanks to everyone for joining. Looks like we've got a really good-sized group today, and hopefully we can get some good feedback from folks. Just a quick note, I think Linda had noted that we are recording this session, one, for purposes of note-taking, but if there are comments that individuals would like to make that they do not want recorded, please just let us know. We'll hit pause. We'll give you an opportunity to make your comments and then go back to recording. So just wanted to make sure that everyone understood that. Really want to encourage as much feedback and participation as possible. And then one other thing to reiterate as we dig in is, Linda had mentioned this is not really, it's not intended for a Q&A as a Q&A session. It's really a listening session for us around some specific questions to obtain as much of your expertise and insight as possible, and really identify those considerations that the board needs to be aware of as it seeks to fulfill its statutory obligations to develop a plan for establishing UPLs. So I just wanted to say that out at the outset. We've got a number of structured questions that are kind of grouped into certain categories, and we'll kind of go through as much of this as we can today. And then we have another call scheduled to follow up on items we're not able to get through, and hopefully get additional input from folks who were not able to attend today. But just as kind of let's call it a guide for things to come, we really want to start by talking about the impact of drug affordability generally, just to do some level setting and get your perspectives. Talk a little bit about the potential impact of the UPL. Talk a bit about implementation. We've heard a lot from other constituent groups about some of the necessary systems changes, things like that, that might be required to implement a UPL. So we've got a number of questions there. We'd like to talk a little bit about UPL methodology specifically. As Linda noted, a number of states are looking at this, and I think there are a number of potential opportunities or directions that the Oregon PDAB may want to consider. And so we want to get your input on potential methodologies and what types of considerations should be made. I want to talk a little bit about the desired state of drug affordability, which I appreciate maybe a little esoteric. And then also at the end, talk about any other or additional recommendations or other strategies that you might have or might suggest that the board consider moving forward. And those could be outside of the PDAB activities related to UPL. So thinking about the board's function and responsibility, and if you have recommendations or thoughts on other concepts or strategies that the board should be considering. So, and Linda, just a heads up, it looked like your Outlook popped up there. So you're probably balancing multiple screens, so I can appreciate that. So let's just jump in and talk a little bit about just affordability generally, to sort of level set and see sort of how this group perceives that. And really want to set this conversation aside from the implementation discussion, which we'll talk about a little bit later, and gather your thoughts on how a UPL might impact drug affordability. I guess I would start by saying that, I think there's certainly widespread belief that, many pharmaceuticals are out of reach for many Americans just due to cost issues. I'd really like to hear from folks, about how you perceive your organization's ability to address some of these challenges. And this, could be through a UPL or not. But really want to think about or hear from you all in terms of where you think you may be able to have an impact, like I said, on overall drug affordability. And so we'll open it up, and feel free to use the raise hand feature, and we'll get going. Great. Asher?
Thank you, Bobby. Ashore Lissick with PhRMA, the trade association that represents many of the manufacturers here on this phone call today. Thank you for asking about that. I think every single company who's on this call today, at the core of their mission is to develop treatment and cures to either address unmet need or create new treatments where there haven't been any before. And there is an absolute recognition of from these companies that this advancement is only as good as patients have access to those drugs. And unfortunately, today we don't have equal access or affordability to those treatments that are available. And I think there's a lot of drivers for that. I think the biggest driver that's going to impact a patient's ability to afford healthcare in general is going to be if they have insurance or if they don't. And then even when a patient has insurance, they may face underinsurance where their out-of-pocket costs are simply too high. So our companies have done a number of things to address those access and affordability concerns. I can name a few of them, and then other people can add on as needed. I would say the first is patient assistance programs. These are programs that give drugs away at a low cost or no cost to patients who have low income. There's over 900 of these different programs that are offered by our member companies, and you can see all of them on mat.org. Another way in which manufacturers are helping patients better afford their drugs is through cost-sharing assistance, which is meant to help people who are underinsured access their drugs through low and predictable costs. A patient would pay a nominal amount to the insurance company when they pick up their prescription drug, and then the manufacturer would make up the difference of the amount that they would have owed and pay that directly to the insurer. Those payments totaled $23 billion in 2023 and have totaled over $84 billion in the last 5 years. Another way in which we make drugs more affordable is through the 340B and Ryan White programs. The idea there is that manufacturers sell drugs at a low discounted price to entities that serve the low income. For people like me, that may go to a hospital that also serves low income, the hospital would bill my insurance a marked up version of that prescription drug. So then they can expand access and offer additional services with the markup dollars to low income patients that do go to those hospitals. The other thing we offer is bridge programs. So after a clinical trial, there is a gap period typically before a health insurer would offer that prescription drug as part of their insurance coverage. So many of our manufacturers will provide drugs free of charge to those people who participated in a clinical trial before insurance becomes available for them. And then I think the thing that you probably have heard of the most, because it is clearly the biggest way in which we make prescription drugs more affordable, is rebates and discounts that we are paying to pharmacy benefit managers, or PBMs, and to health insurers and government programs. Those totaled $256 billion in 2022. And I'll stop there and others can chime in too.
No, thank you. That's very helpful. Other folks have comments or thoughts that they'd like to share?
Good afternoon. I'll jump in if no one else
Great.
is. Hi, everybody. This is Chris Herbine with Johnson & Johnson. Nice to meet you all. I just want to start by thanking Oregon PDAB Board really for seeking stakeholder input. And we do appreciate that opportunity to be able to provide input today. So thank you for that. I just wanted to add a little bit to what Asher was saying in terms of support we provide to patients to make medicines more affordable. At Johnson & Johnson, we're obviously concerned about patient access and affordability and making sure innovative medicines are available for patients, and we can mitigate any concerns of high costs or high out-of-pocket costs or burdensome utilization controls that are imposed upon patients where they're not able to access medicines. I wanted to further outline that, out-of-pocket costs are really a function of insurance benefit design. And that's a really important concept that is determined by the patient's insurer, depending on the type of insurance that they have. And insurers may negotiate with manufacturers like us for rebates, which reduce the overall plan's overall expense, but in some cases are not always shared down the supply chain, ultimately to patients. And that's something that's an important consideration for you to take related to the overall supply chain. When patients are left with high out-of-pocket costs, they may look to manufacturers' patient assistance programs for help, which Asher mentioned in her comments. The majority of commercially insured patients that Johnson & Johnson serves, particularly related to our product Tremfya, which Oregon was reviewing, are eligible to pay $5 or less to fill their prescription. And if patients are unable to afford their medications entirely, either because you're not insured, we'll provide free product to those patients. So in 2022, across our portfolio, which is the only full year data that I have access to right now, we provided support for 1.16 million patients to help them afford their medications through our patient support programs. So I just wanted to provide that context around the broader supply chain, how patient out-of-pockets are determined by insurance benefit design, and then the role we play in supporting patients to be able to afford their medications. So just a few points to add.
Thank you very much. Appreciate that feedback. There are others comments they'd like to make on sort of affordability more broadly, the impact of affordability more broadly?
I'll jump in. This is Michelle Drost from Gilead Sciences. And I similarly would like to thank the board for the opportunity to provide input. I'm going to echo much of what Chris said. Gilead provides significant rebate and discounts on our medicines that impacts affordability to plans.
but we also provide significant patient assistance, as does there are other state and federal programs that help with affordability for Genvoya, which was being considered by the state of Oregon for an affordability review. In particular, there's the federal Ryan White program, the state Oregon Care Assist AIDS Drugs Assistance Program, and then Gilead provides the Advancing Access Program, which is our free drug program and our cost sharing assistance program. As a result of these, 90% of claims across all insurance types in Oregon in 2022 were associated with less than $5 in patient out-of-pocket costs, which means that Oregon patients paid $5 or less for the vast majority of Genvoya prescriptions. Thanks very much.
Thank you for that. Other comments before we move on? Yeah, please, Katie.
Hi, Katie Chandra with Genentech. I too would echo the previous comments, but just want to underscore with regard to insurance benefit design that how a product or drug treatment is delivered to a patient, whether that's a pharmacy benefit or medical benefit, the site of care in which that patient receives that treatment also have substantial impact on a patient's affordability and overall out-of-pocket expenses, including, where they are in the plan year with regard to their deductible or how quickly they may reach a maximum out-of-pocket cost. So we would just urge the board to consider these factors as well.
So Bobby, I was wondering if maybe we could ask Katie to expand a little bit more on that.
Sure. So I guess with regard to different modalities for delivering a medicine, if a medicine is infused, for example, those medicines are often covered under an insurance benefit design on the medical benefit, which can have different cost sharing obligations for a patient than when a medicine is taken orally and delivered via a retail pharmacy or other means of pharmacy drug delivery, mail, specialty pharmacy, et cetera. So depending on how an insurer treats that particular medicine and where in their benefit design they cover that, it can have be subject to different cost sharing requirements at different points. Also with regard to affordability, an infused medicine may also come with office copays, might be based more on a co-insurance design versus a copay design. So it really does depend on the insurer's benefit design and other factors relating to when and where. I think one of the other speakers also mentioned, depending on when a medicine is delivered or where a medicine is delivered in terms of site of care, there may be markup on the cost of that product associated with that, which is why you will get a differential between a WAC cost, for example, wholesale acquisition cost, and sort of a total amount paid. And so there's a lot of literature available with regard to markups on drug costs.
Great, thank you. I just wanted to make sure we captured exactly where you wanted to go with the conversation. So thanks.
So I think, there have been a number of comments thus far that really kind of dovetail or lead nicely into the next set of questions that we have in thinking about the potential impact of a UPL. There was discussion of benefit design as an example. We've asked a number of constituents, or we've heard from constituents rather that, suggest that, a UPL could prompt changes in benefit design, changes in utilization management strategies, things like that in response. Is that something that folks here have thoughts on? Yeah, go ahead, Asher. And I apologize. I think I've been saying it wrong. Can you say your first name for me one more time?
Yeah, it's Assure. It is spelled like Asher. And it's no worry. I've been doing that since I was 5 years old. Yeah, happy to speak to how a UPL could impact affordability. And I do think one of the questions out there is how the board wants to define what affordability is and who they're trying to make drugs more affordable for. I think from our perspective, the conversation really needs to be around that patient and that consumer, and that is who is first and foremost in our minds. So to answer your question, yes, I do think that a drug, UPL, could impact drug affordability. I am concerned that it could impact it in a negative way. And at the heart of my response before we get into it is that we are really working in a broken system in how we pay for prescription drugs in this system. Right now, there are people in the drug supply chain that negotiate discounts and rebates. And because they are able to make their money off of discounts and rebates, there is a perverse incentive in the system for PBMs to prioritize higher list price drugs that have larger rebates on their formulary. And so right now, this conversation of looking at a UPL is being done in a vacuum. It's looking at what manufacturers are going to provide to the wholesaler. And it ignores the market forces that are going to ultimately impact what a patient is going to pay for their prescription drug. So to date, no state has ever said that a patient must benefit from the UPL through lower out-of-pocket costs at the prescription drug counter. No state has also said that you have to cover a drug that is UPL'd. It doesn't say that they have to provide cost sharing on a lower cost sharing tier, that drugs that with UPLs will only be subject to copays. None of those patient-friendly forces are in these UPL statutes. And so what is likely to happen? Well, since our system prioritizes and incentivizes brand drugs with higher rebates, then if a drug is UPL'd, it may be excluded from the formulary or placed on a higher cost sharing tier because those people in the middle are not going to be able to collect rebates and discounts off of the drug. Also, if you think about this in the physician administered space, they're no longer going to be able to make markup on the drug. And a lot of physicians rely on markup from drugs to actually account for their time and expertise in administering those prescription drugs. I know in the past, our organization has been accused of fear mongering around this. I will say that there have been several studies that have been done by national researchers that have found that payers are not anticipating to share savings from the UPL with patients in the form of lower premiums, deductibles, or cost sharing. Those are direct quote from payers and what they say their response to a UPL is going to be. I also want to highlight data that has come out around MFP, which is a different version of a price control at the federal level. Recent study found that the MFP drugs, for patients taking them, they're likely to see a $3.5 million increase in their out-of-pocket cost by 2026. And so we're very concerned that when PDABs are looking at this in a vacuum, they are not considering the market forces that will ultimately determine what a patient pays for their prescription drugs, and that there's nothing in statute that protects those patients and consumers at the end of the day.
Thank you, Chris.
Thank you. I just wanted to add, again, Chris Herbine, Johnson & Johnson. I fully support Assure's point around the fact that whatever change is made, we really need to think about the impact on patient cost share as the end game solution. And if you look at that from that perspective, our feeling is that UPLs are unlikely to create any cost savings for consumers or direct purchasers. Patient out-of-pockets are set by health plans as part of insurance benefit design, and health plans often base their patient's co-insurance on the list price of the product of a drug rather than the net price or that plans receive. So a lot of times it's not passed through to the patient. And I think Ashur was mentioning this before, but I did want to share that recently an Avalier study commissioned by the Partnership to Fight Chronic Disease further supports this point. In the survey, health plans stated payers will not pass their savings, if any, on individuals. It's not realistic, and someone will need to make up a difference. That was an excerpt from the study. Interview plans also stated that they were unlikely to lower plan deductibles or maximum out-of-pocket limits as a result of a UPL. So we recommend, as the board contemplates the affordability reviews in UPLs, we urge it to consider the entire supply chain ecosystem and the complex ways in which each part really impacts affordability for patients.
Thank you, Chris. Just to tease out a couple comments that you made and that Ashur made. What are, if what can the board do, or what are your suggestions or recommendations or thoughts on what the board can do to attempt to mitigate some of those things, or attempt to ensure that, as you both put it, that those savings that could potentially be generated are passed through to the consumer? Do you have any recommendations or thoughts on, approaches, models that could be, or policy decisions that could be made to ensure that that's the case?
Yeah, really good question. I mean, the three things that I would recommend, and operationally, obviously you have to figure out how to do it, but require that rebates, discounts that PBMs and health insurers receive from manufacturers be directly shared with patients. That would be number one. Number two, really look at, examine the use of utilization management tools and how to regulate them to ensure that patient access and minimizing out-of-pocket costs are the main objective. And then finally, prohibit diversion of cost-sharing assistance to ensure payment made by or on behalf of patients count towards their cost-sharing burden. Those are three things to consider.
Thank you. Appreciate that. One quick question, just to make sure that I captured it correctly. Your first comment about requiring rebates be shared with patients. Are you suggesting sort of a full pass-through model, or something a little more, something more nuanced? What did you have any particular thoughts there?
Yes, or a variation of. I think you have to dig into the details a little bit.
Sure.
Yeah.
Sure. Any thoughts on that same question in terms of things that the board should consider or contemplate to potentially mitigate some of that, or ensure that those savings are passed on to the consumer?
Yeah, I think that there is a general lack of clear basis for the direction of the board. Right now, the board seems to be prioritizing system level costs. Like, for example, when the board initially reviewed insulin products, every single insulin product was found to have less than a $10 out-of-pocket cost to patients, but it was still found to be unaffordable. And quite frankly, it's not clear why some of those insulins were deemed affordable and others were not. And so there is a total lack of consistency or clarity in what the board's purpose is. And I think until that mission is changed to be fundamentally about patient access and affordability, those concerns that you're hearing are still going to be at issue for manufacturers.
Great. Anyone else have thoughts on that same line of questioning?
Yeah, this is Michelle from Gilead again. I'll chime in on the idea of additional policies. In the HIV space, one idea that you might consider, again, going back to Genvoya, is that you could take steps to ensure that all Oregonians with HIV are aware of and benefiting from the programs that are available under state and federal law, just in case there isn't good awareness of those programs.
Thank you. Okay. Similar to some of the things that I think folks have mentioned on the call already, and that we've heard from some other constituent groups, is the idea that setting a UPL could potentially create challenges for patient access. Particularly that Oregonians may not be able to get certain medications. Is that I think based on some of your comments earlier, it sounds like you would agree that that's a valid concern. Is that something that that the board could take certain steps to ensure that access or drug supply is not limited or inhibited in the state through UPL?
I can jump in on that one as well. I think if you go back to the slide where the underlying basis for making a UPL work was some of the decisions of individual companies to lower WAC prices, I think the rationale that was given there we would disagree with. But I'd like to point out that when companies are decreasing WAC, they are doing that at the national level, and that is impacting prices in all 50 states. It also has impact on national pricing metrics such as best price, which you also mentioned on this slide. It is unclear to us how the state plans to use an exact parallel like that because it would only be for the state of Oregon. This would not be a national lowering of a WAC price. It would be a UPL, as was put in the previous slide, replacing WAC in the state of Oregon. And there's a lot of unanswered questions about how that would work on an individual state level.
Other questions or thoughts on the access concerns or implications for access? Go ahead, Katie.
I was just going to raise, in an earlier slide, you reference a UPL as a reimbursement methodology similar to a full or a MAC. And I think, again, when you think about different products, physician-administered products, for example, we know that there are existing access challenges where reimbursement is not sufficient to cover acquisition cost. And Medicaid patients, for example, already have challenges with access to specialists in particular due to low reimbursement. So would consider not only some of the benefit design elements that we've been talking about today, but also the effect of low reimbursement and how that's playing out even before the introduction of a new reimbursement methodology.
Thank you for that. Okay. Any other thoughts on, we talked about the impact of UPL in terms of benefit design and access. Any other thoughts around other potential impacts that we have not discussed? Just want to make sure we're being thorough and capturing your concerns.
The only thing I would bring up, going back to that schematic you showed of how potentially a UPL could be effectuated. I think it had the boxes and the flow chart. Yeah, it was, I think, the one before this, maybe. Yeah, this one. Yeah, the only thing I would highlight here, depending on where you put that UPL application box, could dramatically change the answer to your question. And I think it really comes down to how would that be effectuated through the system, and based on where that's effectuated, what is the corresponding response by each stakeholder in this schematic. So it's even difficult for us now to anticipate all of those things, because each individual stakeholder may react differently and take different decisions based on how it's effectuated, how it affects their overall business from a health insurer standpoint, how it impacts their formularies, how it impacts the patient out of pockets. All those things trickle down to impact other things. The other element of that is at the pharmacy level, depending on where it's effectuated. Somebody else mentioned on the call, there's already reimbursement inequities in the pharmacy system today. Could that extenuate those circumstances such that it creates a unique dynamic in the retail pharmacy channel that then creates access barriers for certain products because of the UPL? So I think those are all concerns based on how the process gets effectuated and what the corresponding reaction is to each stakeholder in the supply chain.
Great, thank you. Let's talk a little bit. We've talked about impact. Let's talk about a little bit about implementation, which I think, Chris, your comments certainly, sort of point in that direction. I think that across the constituent groups that we've been talking with, we've heard a number of comments or concerns that a UPL would be challenging to implement, not only for some of the points that you just made, Chris, but just in terms of operational challenges or concerns around members or payers being in other states, systems challenges, implications, things like that. I'm curious, from your perspective, from the manufacturer perspective, in terms of implementing a UPL, if one were to be established, are there specific challenges that you see from your organization's perspective?
I can start us off again there. I think first and foremost at the onset, we have all watched the board work on affordability reviews this year. And there seems to be some issues in even properly selecting drugs that meet the affordability review criteria, and doing drug reviews in a consistent way. There's, I think, outstanding questions around data sources. And I think, until we can get those conversations right, looking to expand the board's authority to get into even more complex areas is really difficult for us. I think, we're also concerned that there doesn't seem to be a patient voice on the board, or specialty physicians that can even really help understand the clinical impact of a drug and the implications that putting a price control on those may have. So I think we got to get they got to get the basics right, and right now we're pretty concerned that that's not happening. Also, I think there's a lot of unanswered questions, back to Chris's comments around the supply chain, as far as how the market forces would react to something, especially since there's nothing in statute that regulates what they will do in the system, how they can respond with rebates and discounts, how they can change patient out-of-pocket costs. And quite frankly, what we have heard about the UPL implementation process has been different. You know, we've participated in every single state and listened to every piece of testimony that's been given. And the exact mechanism for what they're considering keeps changing. Honestly, some of the slides today were new information to us that we had not heard before. Like on one of your slides, it says, well, the UPL doesn't regulate how manufacturers set prices. But then you have the graphic that says that the UPL will replace WAC and AWP, which seems to be directly contradictory to that. And so for those reasons, you know, we're really concerned about implementation and feel like there's so many unanswered questions here.
And just to tease that out a bit more, and, you know, to your point that, you know, from your perspective, it sounds like, you know, the unanswered questions may make it difficult to even suggest opportunities for, or make recommendations on implementation. Is that a fair statement?
Yeah, that's exactly correct.
Do other folks have thoughts on that as well? Just implementation of a UPL, or different thoughts rather? Ms. McCaffrey?
Hi, this is Alyssa McCaffrey with Takeda Pharmaceuticals. I just want to echo what Ashur was saying, really, because I think that we share similar concerns about some of the fundamentals. I know I haven't spoken yet, so I will just take a moment to thank you all for the opportunity to participate. We really do appreciate the thoughtful discussion here and the PDAB's willingness to hear the manufacturer point of view. But I do just want to echo some of the comments that were made kind of throughout the meeting today, that we believe implementation of an upper payment limit would work against our shared goals of lowering patient out-of-pocket costs and removing barriers to access. And some of the concerns that have been highlighted around the negative implications on other stakeholders like providers and pharmacists are also concerning to us. And so I do think that given those concerns and the way we think a UPL could actually interfere with a patient's ability to manage their condition in a manner that they and their physicians deem best, we would recommend that Oregon discontinue pursuit of the UPL methodology until they can get some of the other pieces that Ashur was talking about aligned and consistent. And so we do hope that the PDAB would consider some alternative methods of supporting medication affordability and accessibility. And I know Chris listed out a few of those earlier, so I would just kind of refer you back to some of those other methods that might be more consistent with our goals of patient affordability. Thank you.
Thank you for that. Next question. And again, we may have sort of teased this out already. I mean, I think based on some of your prior comments, but you know, are there solutions that you know, you might suggest that a wholesaler or a distributor could offer to solve some of the concerns around a UPL, specifically related to kind of out-of-state patients or pharmacies? Whether that's an option to leverage a single wholesaler for certain products. This is just something that we've sort of heard, excuse me, in a couple other groups. Just didn't know if folks had thoughts on that.
Can I just ask a logistical question? I mean, that seemed to be directed at wholesalers. Are wholesalers on this call, or are they part of a different call?
They are part of a different group, but we thought that while we had you, just given your understanding and relationship with, you know, with the various stakeholders, we thought we would ask the same question. So,
yeah, I appreciate that. Unfortunately, I can't speak for what the wholesalers may or may not do.
Next question, and I think we've probably kind of touched on this as well, though not maybe using these exact words, but survey responses and other constituent groups have suggested that transparency is a critical component of this exercise that the board's undertaking, and that that would be critically important to UPL program. Any thoughts on that? What does transparency mean from your perspective? How can the board ensure that they're demonstrating transparency in these processes? Any information that the board might need to sort of make sure that they're publicly demonstrating to constituents across the supply chain. Any thoughts there?
I mean, the only thing I would maybe add there is just continue to seek patient consumer voice in the process, whether it's as a extended member of the PDAB or at least in some way continue to seek input and feedback from the patient voice to ensure that the overall goal of this is really to impact patients and improve their quality of care. So I would say that's something to consider.
Any particular, in addition to sort of making sure that the consumer or the patient voices are heard, any thoughts on information that the board should be sort of active? We've talked about some of the areas where you feel that some more insight is necessary. Are there certain things that you're looking for that you want to hear from the board that would sort of alleviate any concerns that you might have around the board's transparency in this process? Whether that's data sharing or whether that's things like that.
The pharma has been engaged in the board process over the last year, and we've submitted several letters over that time period, highlighting specifically where we would like to see more transparency and more clear and consistent standards. I can get those letters to you, but that would be the best place to get a comprehensive look at the places where we are looking for more clear outlined rationale or the basis for certain data, and then the areas where we would like to see consistency in even just the drug review process as it's currently going through.
That's very helpful, and we'll work with the folks on the board to make sure that we see if we can capture that information and make sure that it's part of our report of the stakeholder engagement activities so that we can capture that. So, okay.
Thank you for that.
Yeah. So I know we're right at time. I really appreciate everyone's willingness to share your thoughts and your feedback. We do have another session scheduled, and I would say based on kind of the conversation so far, we've probably got about just as many questions that we'd like to go through, and really hope that folks are able to join us for the next call. If not, though, as Linda had pointed out, there's an email address here that you can submit any direct comments to us. We'll make sure that all gets captured and incorporated in our findings back to the board. And then there's also, obviously, which it sounds like a number of you are already familiar with, the opportunity to submit direct comments through the board's website directly. And I think she looks like she's got those dropped in the chat as well. So we will look forward to hopefully speaking with you all during our next meeting. And again, appreciate your time.
Thank you both.
Thank you, Bobby. Thank you.
Thank you. Have a great afternoon.